Welcome to the second episode of Pharmacist Matters podcast. I'm your host, Justin Bates. On today's podcast, we have the pleasure of having Daniel Chiasson, who's the President and CEO of the Canadian Association of Pharmacy Distribution Management. Daniel's a senior executive with supply chain experience and proven leadership in driving growth, profitability, and collaboration within the healthcare and food and beverage industry sectors. Prior to joining CAPDM, Daniel served as Vice President of Supply Solutions at McKesson Canada. He's also held senior executive roles at Shoppers Drug Mart, Cardinal Health Canada, and MDS Inc. We have three pharmacists as panelists, starting with Chelsea Geen. Chelsea is a University of Toronto Leslie Dan Faculty of Pharmacy graduate and is a pharmacist now at PharmaSave in Southern Ontario, who has been practicing for 2 years. Gary Wong, who is our pharmacy clinical manager at University Health Network in Toronto, will be talking about challenges related to both operational and clinical COVID-19. And Joshua Pusong, who is a second-year University of Waterloo School of Pharmacy student. He has worked most recently at the Markham Stouffville Hospital in pharmacy until the end of March. These are certainly surreal times, and as it relates to healthcare, we really are seeing a number of challenges with respect to patient access to care, the continuity of care. And it's one of the reasons why we are going to be talking about some of our lessons learned and best practices so that we can share our stories and experiences. And hopefully, as we work together through this, we come up with solutions and really come together as an industry and as a profession. I know that pharmacy professionals are proud to serve on the front lines, and they're helping patients every day manage through this pandemic. That said, there's a lot of stress and anxiety, and certainly having to deal with these unprecedented times is taxing every part of the healthcare system. And I know I'm personally proud of how pharmacists and pharmacy professionals have stepped up to really answer the call. And we're showcasing a lot of the value and the important role that we play in the healthcare system. And if there's a silver lining in all of this, it's that we are demonstrating that to the public. We're changing people's perceptions of the practice of pharmacy and the role we play in the broader healthcare system. But we're also engaged on a regular basis with government and private payers to better work together on solutions around scope of practice, around the various components of how do we better enable the frontline and protect the frontline to serve patients that will last well beyond the pandemic. We are seeing some positive signals from key indicators with respect to flattening the curve. I think for the first time in the last couple of days, we're starting to see that these measures of stay-at-home social distancing is working. If you look at what's happening on the front line from a pharmacy perspective, innovation, creative ways to safely manage patients, you're seeing stores that are putting in physical barriers, whether it's plexiglass or other mechanisms to maintain that social distancing within the store to keep their patients safe. We're also placing posters at all of the front store on the doors to ensure that patients do the self-assessments. And if they're sick, we have certainly encouraged patients to stay home, phone their pharmacy, utilize some of the virtual tools that are available, but also to look at increasing our capacity around home delivery of medications, curbside delivery, and flexing hours so that those that are more vulnerable in our population have an hour, designated hour to come into the store. Other best practices have been worked on with pharmacy associations around how and when to use personal protective equipment. Certainly that is one of the increasing challenges in terms of being able to safely manage patients. We need to ensure that pharmacists are not only designated as essential healthcare providers for priority access to government stockpile of PPE, but we also need to make sure we're using it appropriately. And that's part of what at OPA we have done to ensure that we have some supply of PPE for Ontario pharmacists, and we are continually looking at secondary and tertiary suppliers to offer that as a service. But as everybody knows, there's a global shortage there are logistical challenges. But I think it's really important that not just for pharmacists, but for all healthcare providers, that we give them the appropriate equipment to manage their patients. As part of what we've been doing with government is that we're putting forward proposals that will enable greater scope of practice around things like emergency prescribing, certainly looking at therapeutic substitution to help manage drug shortages, and expediting the regulations for 12 treatment and assessment of 12 common ailments. In addition to that, we are looking at an economic relief package to ensure that no patient is having an additional financial burden as a result of the 30-day supply limit that was necessary to be implemented in order to protect and maintain the supply chain, as well as some other economic packages to help offset the increased operational costs as a result of managing stores and safely managing their patients. In the early days, we say early days because we're really in week 5 of this pandemic, but in early March, we started to work with the Canadian Association of Pharmacy Distribution Management and other stakeholders to advocate to governments in Ontario and, of course, across Canada to limit the supply of medications so that we would prevent drug shortages. And today we have Dan on the line to chat a little bit about, is that working? Did the 30 days meet its intended outcome?
Oh, thank you, Justin. It's a pleasure being with you and the OPA and members of the pharmacy community. And kudos from the top for the work that pharmacists do day in and day out, and particularly in times of crisis. And Justin, we from a distribution perspective, we're very, very supportive of the 30-day medication supply limit that most governments adopted in mid-March. If I go back to the first weekend of the pandemic, we essentially were wiped clean as distributors in terms of large orders, huge demand spikes across the board on all medication. And there were some early signals that the industry, pharmacy and distributors, were sensing that there was some panic buying and stockpiling going on. And so there was a real need to manage the demand side. There was no issue from a supply perspective, assuming normal historical demand patterns, but we weren't living in normal times, and there was a lot of, as I mentioned, pent-up demand. So the 30-day policy that pharmacy advocated for and we supported strongly, I believe had the intended effect. We're now in week 5, and we started to see the benefits of that in about week 4. So last week and this week, stocks are slowly but surely being replenished in the warehouses. It's too early yet to take the foot off the brake pedal. It needs a couple of cycles for manufacturers to feel comfortable that their own pipeline will be able to sustain the demand patterns, particularly as we resume going back to what I would call quote unquote normal activity. And at the point where manufacturers are ready, then it'll take a few cycles for distributors to stock up, and then it will take a few cycles as well to get all pharmacies across Canada well stocked to resume what I would call the normal 90-day script patterns. So that's where we're at, Justin, from a 30-day supply perspective. We've also had to put in place manufacturer-driven allocations. Again, that's another way of managing the demand side. But as I previously mentioned, other than drugs that are impacted by the COVID treatment, other drugs should be resuming their normal demand patterns, and we're starting to see some early signs that manufacturers are starting to remove some of these allocations. Again, it will take some cycles before we can get back to what I would call normal activity, but there's some encouraging signs on that front.
Have you been engaged with media and talking about some of these things? And I think sort of a follow-up to that would be, have we seen any drug shortages from directly related to COVID-19?
Yeah, so there's been obviously some media coverage around the 30-day, and CAPDM has been quite clear in our support for the 30-day policy, and indicating as well, both through media and through open letters to industry stakeholders and some direct letters to government officials as well, that the time is not now to release the 30-day limits. We will get there, and there's an economic interest for everybody to get there as quickly as possible. But I think you mentioned about doing the right things and being responsible. I think despite the fact that it's not economically beneficial to put those limits in place, it is the right thing to do to ensure that patients will get their medication when they require their medication, and we're still advocating that they shouldn't be ordering more than what they really need. The supply chain will be there for them. Now, with respect to the question of are we seeing some drug shortages? No, if we go back to mid-March when the pandemic was declared on a global basis, we did see some shortages that were driven by demand spikes, and we've talked about this already. As we project forward, what we anticipate is that there will continue to be some shortages on medication that is used for treating COVID-19 patients, and whether it's medication that's used in ICUs, such as sedatives, neuromuscular blockers, analgesics. Those, we're already starting to see some of the shortages pop up, and with the healthcare system looking at ways of mitigating those shortages by Health Canada is being very, very proactive in allowing exceptional importation authorization for drugs that could actually be substituted for those that are in short supply. And the other piece that we're also seeing is a crossover of products that are typically in the community pharmacy setting, but are being used increasingly in the acute care setting, and specifically the antivirals, hydroxychloroquine, chloroquine being an example of those, and the metered dose inhalers, where we've seen a change in protocol recently by hospitals away from nebulizers towards using the metered dose inhalers that you would see typically in a retail setting. So those are causing some imbalances between supply, which is there for normal demand patterns, but we are seeing those spikes, which is creating shortages that I think will persist in certain regions of the country, particularly where they're more advanced in terms of their COVID cases.
One of the things we've been advocating to the Ontario government for is for the government to step in and pick up the additional co-payments on the second and third dispense, given a typical 90-day cycle going to the 30 days. We are encouraged by those discussions, but we continue to urge the government to move in on that, because we don't want to put any patient in any financial stress during this time. In addition to that, when I think about the 30 days and all potentially syncing up to that period of time, how do we, in your mind, how do you envision rolling this back out to 90 days? I would assume that there may be some challenges if everybody's synced up and suddenly turn back to a 90-day cycle. So are there discussions with government, Dan, about how we would transition and maybe stage this over a period of time?
Yeah, so the conversations are ongoing. Obviously, there is consumer pressure and political pressure to get back to 90 days as quickly as possible. Our belief, given our visibility into the supply chain, both at the manufacturer level and with distributors, is that this will likely be done in a gradual fashion, where certain categories or therapy or course of treatments will be able to come online to a normal demand pattern, or normal supply pattern, I should say, in a gradual fashion. And I think we're still weeks away, because, as I mentioned, we're starting to get some early signals from manufacturers that their inventory position is moving in the right direction. It doesn't necessarily mean that the inventory positions at pharmacy or at the wholesale level are still where they need to be to resume normal supply, but we will get there gradually. And as I mentioned, it's not going to happen overnight, and it's not going to happen with the flip of one switch where everybody goes back to the 90-day supply. That in itself, I believe, creates some challenges, and pharmacists are probably better positioned to talk about this in terms of how to execute, certain categories of products going back to 90 days while others remain on the 30-day. And so this is something that I'm less conversant about, but we believe that, at least from a supply chain perspective, we're probably weeks away from being able to open up the supply chain to the 90 days on a gradual basis.
Thanks, Dan. I think that gives Canadians a lot of confidence in the planning that's gone into this, the rationale for rationing the supply to 30-day limit, and in fact that it's working. I think that reassures everyone. When we look at, I want to transition over to our panelists at this point, and one of the things that we're hearing about, and it makes a lot of sense given the closures of clinics, doctors moving to more of a virtual care model. In fact, many doctors are giving their time in other parts of the healthcare system, such as palliative care. What that has done is it's created an influx of patients coming to the pharmacies looking for community-based health services. And that's both an opportunity and it presents a challenge given the challenge of the risk of exposure of COVID-19 between patients and pharmacy professionals. But it also gives us an opportunity to work with patients and demonstrate the access that we enjoy in terms of having over 4,600 pharmacies across the province. Chelsea Geen, you're a University of Toronto Leslie Den Faculty of Pharmacy graduate. You're a practicing pharmacist now with a PharmaSave store in southwestern Ontario. You've been practicing for over 2 years. Certainly, these are surreal times as it relates to the conditions that we're all operating in. I know you wrote a very passionate, we'll call it a blog on Facebook that caught a lot of attention for its genuine nature of concerns that you expressed. And really, I think you did an excellent job in capturing what it's like on the front line. Wanted to get you to comment a little bit on what you're experiencing, what you're seeing, what are those challenges, and how do you feel as a pharmacist today? If you could share those experiences, that would be great.
Sure. Thanks, Justin. Well, I know there are a lot of challenges that we're all going through. I think one of the biggest challenges is how much pressure is being put on the pharmacy staff. So, our staff are warriors and they're doing an amazing job, but they're also pretty exhausted. And I'm sure we all sort of feel this way. But everyone is just doing their best and we will make it through this. I think the first 2 weeks were a real adjustment with the explosion of requests for prescriptions. It really was nonstop. Pharmacists were, staying extra hours to clear all the baskets, check blister packs, all that sort of thing that couldn't be done during the day. And another challenge that you'd already kind of touched upon is trying to fill the gaps in the health system right now. So especially in primary care, a lot of doctors are still providing virtual care for their patients, but they are a lot harder to contact. So people are looking to pharmacies for medical advice even more than before. And obviously exposure is a concern without any PPE and going home to our families and having concerns for their safety as well. And we are actually getting a high number of requests for injections from patients and doctors, not just for vaccines, but actually for medications as well. So unfortunately, without appropriate PPE, we're not able to do that for patients. But it's something that is interesting that it has kind of spiked in that way. And then you mentioned as well operational differences. So deliveries have increased. We've had to come up with a delivery protocol for social distancing, including screening before sending things to people or knowing how we're supposed to, deliver their medication, ensure the patient receives it, and also figuring out how to adjust store hours and limit the number of people in the store at a time, reallocating staff and screening at the door. And we have had challenges that way too. Unfortunately, some people have been, untruthful about their symptoms. So that also just adds more stress to the staff. But most patients are really great with it. So I think the important thing too is we're acting even more as a liaison between patient and doctor. So we'll even get blood work requisition forms from doctors that the patients come in to pick up. So we are really, that true front line for all of the patients. So overall, not only an influx added to the regular workflow, but in other areas as well. So it's just been challenging balancing it all, as I'm sure many of you are finding.
That's a great perspective, and I think it really gives our audience a frontline view of what actually is happening and the challenges that you're faced with on a daily basis. You mentioned about the personal protective equipment, and that's obviously something that has received a lot of media attention. Government is challenged in getting replenishing supplies. We know that critical PPE like the N95 masks are in short supply for long-term care homes, nurses, physicians, and pharmacy. Can you talk about, do you have PPE? And what kind of PPE are you looking for? And would that give you the sense of security that you require?
Yeah, so what we have done, we do have some, plexiglass kind of screens that we've tried to hang from the ceiling in the dispensary areas and up at the front cache. We do have that protection. We have ordered we're lucky we had that partnership that OPA developed with Ronco. So we have ordered supplies from there. We did get some surgical masks in just this week. So that's great. I actually had a kind of an inspiring comment there on the mask last week. I was talking to someone, it was a community member. They found out we didn't have any masks as health workers on the front line, and they were so concerned. They asked if we were taking donations, and a couple of days later, they brought in a new box of 50 disposable surgical masks. So that really made the staff smile. So that was kind of a neat story. So we started having masks as of last week. And then, like I said, the OPA that ordered the masks came in. We're still, I think we also ordered the gowns. And so, it's slowly kind of coming to, like you said, make us feel a bit more protected and secure in our jobs going to work every day.
That's great, and I'm glad you were able to receive the first order from Ronco. If I asked you a question about what you need, what's the support, whether that's scope or anything really, that if you could talk to government directly, what would you say? What would be your ask as a frontline healthcare provider?
That's a good question. I think the main thing would just be one, the recognition that we are on the front line. We're frontline professionals. We're doing our best, and we're here to care for patients. And in that way, we, should be prioritized just like all the other health professionals out there. I know, like you said, there is a short supply, and we slowly are getting some protective equipment, so that's a good sign. But I think just that underlying support and recognition that we are out here, kind of taking the place of many professionals that, are working from home, or people that, aren't available as much for patients, and even just looking for comfort or what to do in certain situations, they're calling their pharmacy. So it's kind of both sides. It's great that we can be there for our patients, but I think it's also important that the government can recognize everything that we are doing. And I think even it's really important during this pandemic to kind of reflect on what we're accomplishing every day in our pharmacies and as professionals, realizing, how capable we are, how many skills we do have, and how we've all risen to this unforeseen challenge. And just to remember all of this when the situation's over, so we can kind of go forward with a renewed sense of our value as a profession.
And I think that's spot on. I know I speak for many people in saying we appreciate what you're doing. You have our full gratitude. And certainly, I know in my conversations with government, which are happening very frequently, that government also recognizes the challenges. And there's obviously a lot of different moving pieces within the healthcare system. But I do believe that both from a public perception perspective as well as government, that we are showcasing the value and the accessibility that we offer for patients, and that will serve us well beyond the pandemic. At this stage, I'd like to bring in Gary Wong, who's the Pharmacy Clinical Manager at the University Health Network in Toronto. Gary, you practice in a hospital setting, and we just heard from Chelsea with respect to the community-based care model and some of the challenges and what's happening. Really would like to hear from you from the hospital perspective. What have you experienced? What are the challenges operationally and clinically?
So thank you very much for this opportunity. I was going to say, I think the hospital has had a quiet voice in this. And that's because normally we're a black box and people aren't familiar with what is exactly going on. But I'd have to say COVID has really changed the hospital practice. We have been mandated to increase our ICU beds from 98 to 196, so doubling of our ICU beds. Our general medicine population usually runs about 200, 225 beds, and we've been asked to move up to 800 beds. The hospital always runs 95% full historically, so obviously having this 100-fold improvement in capability is impossible without dramatic changes, and so there have been dramatic changes. What we are seeing is in order to empty the hospital, we are not doing elective surgery, we're not doing transplants, we are really limiting the amount of activity in the hospital, and that is allowing us to move from our 95% fullness down to about 65% full in terms of patient load. We've stopped research, we stopped teaching, we stopped clinic work, and all of those are very important because we have, in order to upstaff these other areas, we need to obviously pull in staff, and so getting the small amount of staff that we get from research, stopping our teaching activities and stopping our ambulatory activities will allow us a small pool of resources to bring into these areas. There's no doubt that we've also activated our part-time people and other people to actually that have historically worked for us as other resources. So we've cut down on certain things to allow for the expansion. And I could tell you that the expansion is, in the ICU expansion, it is a lot of work. We obviously have a couple extra beds that we can open up in ICU units that were maybe financially not opened. So there's maybe 2 or 3 beds that get opened up in an ICU. But we've had to open up our post operating room recovery areas. So many of these PACU areas that are used for operational recovery of patients are now turning into ICUs. Our cardiac cath lab is slotted to turn into an ICU as required. And when we do these things, I just want you to realize we need to change floor stocks. We're moving Pyxis machines, which are dispensing machines, into these areas to be able to operationally support these areas. So there's a lot of things that are moving in order to get these ICUs and other floors actually able to accommodate the COVID patients. Some of the other things that people don't realize is when we get this jump in patients, and we're already feeling a jump in patients in our ICU, things like Alaris pumps, the smart pumps, are going to be limited. And so we've actually had to go through our list of medications and decide, okay, these must be administered by an Alaris pump, and these other medications will have to be done by gravity. Historically, we used smart pumps for 90% of our administration, and we need to change that. There's no doubt also, just with the COVID situation and trying to maintain social distancing, we've changed a lot of the way we do our work in the hospital. One good example is trying to conserve PPE for nursing. We're trying to minimize medication administration times. So instead of having classic administration times for patients with COVIDs, we're trying to collapse the amount of times that we're actually entering the room and minimize in our use of exposure and our use of PPE in order to conserve what we have. Most of our work is now done virtually. So the clinic patients that we do see is done on a virtual clinic visit. Even our rounds that we have with our medical team, there's no doubt in the ICU and in the COVID floors, we're doing still face-to-face rounds. But in many of the areas, we're actually doing virtual rounds using the different different platforms that are available for us to do this. Obviously, Skype and Zoom and MicroOffice platforms are allowing us to do virtual meetings. I'd have to say, even when we talk about BPMHing COVID patients, we've taken many important steps to minimize exposure. One of the important things we decided is you can always wait. A person comes into ER with respiratory symptoms, do your secondary sources first, pass BPMHs, talking to the retail pharmacy, using Connecting Ontario, and wait to see if their COVID status, we'll know in 24 hours what their COVID status is. And so wait the 24 hours. When you find that they are COVID-free, then you can approach them, again, using the proper IPAC philosophies. So even BPMHing, we've kind of changed. And there's no doubt that even, the way we use the rooms and the way we have COVID areas and COVID-free areas, we try to maintain that philosophy as much as possible. And we're even using some working from home. Early in this COVID scenario with the travel restrictions, we had many staff that were confined to being at home with the self-quarantining. And so we developed a working from home philosophy, which allowed our pharmacists to be productive even in isolation. So you could see that there's been a lot going on in the hospital world, and just kind of going back up to Dan's comment and looking at therapeutics for COVID patients, I was going to say that there's no doubt that there's a high demand for paralysis and sedation. And, that's actually made additional work for us, which is fine, in the sense that we had to develop conservational philosophies and more appropriate ways to manage patients on paralysis and sedation. But so those are some of the big things that I wanted to mention. And, anyways, I'll stop at that time.
Yeah, that's great, Gary. Thanks for that overview. And I think it's important for our listeners to understand the challenges within the hospital setting. You mentioned virtual care, and it's something that I wonder, as a patient myself, will this be transformative? What we're going through from a societal perspective. You mentioned work from home. You mentioned different areas that are being accommodated operationally because of social distancing. I think we all are wondering whether that will have any staying power and maybe more adoption and acceptance of some of the virtual care options. Because as we look at trying to create capacity in a healthcare system, we're going to have to, for a sustainable healthcare system, or at least to achieve that, we're going to have to look at how do we enable more community-based care? How do we make sure it's the right person in the hospital bed, getting the bed blockers out, the right person in the doctor's chair. And all of these are going to be important mechanisms that will be at our disposal to better serve patients. And maybe that's the silver lining. Maybe we'll have an environment of greater adoption and implementation of these care options. I wanted to bring in Josh Pusong, who is a second-year University of Waterloo School of Pharmacy student. He was working at the Markham Stouffville Hospital in pharmacy until the end of March. Josh, you've been able to hear this conversation from different perspectives, being in your second year and watching all of this unfold. Maybe you can share some of your thoughts.
Thank you, Justin, for having me here. I know Gary addressed a lot of the points from the perspective of hospital pharmacy. So I'll be trying to provide my input mainly from the student perspective. So as a second year pharmacy student, coming to co-op. So co-op is a work term practical opportunity for us to apply our knowledge throughout school as we become practicing pharmacists later on. And so have the COVID-19 pandemic situation occur during our very first co-op work term is definitely something that we definitely didn't expect. So for me, I would say that when I noticed this first occurred, at first I actually saw it as a potential opportunity, like a great learning opportunity, because it's not every day that as a student you get to encounter this type of situation. But as the situation became more serious and it progressed, I would be honest that there were some times where there would be feelings of stress and anxiety. So as Justin brought up, I had the opportunity to work as a co-op student at Markham Stouffville Hospital, where I'd be aiding in the MedRec process. So that's like addressing any medication discrepancies with medications ordered for patients that were admitted to hospital compared to what they were taking prior to admission. And a big role of my position was to perform the BPMHs. So to basically summarize my role, I essentially would spend a good portion of my time talking to patients about what medications they're taking coming into the hospital. And so my position would include various units of the hospital, mainly in the emergency. And so when the COVID-19 pandemic situation started to arise, it made me realize what if there was a situation where maybe a patient I might be talking to might potentially be, suspected of maybe having COVID-19 or whatnot. Now, I have my supervisor reassure me that, the hospital has their policies and whatnot to ensure which patients would be appropriately triaged coming in. Now, before the global pandemic was announced, there's actually a short story I'd like to share where although there were patients coming into the hospital and they'd be triaged appropriately, there would be cases where after an assessment with a physician in the emergency that patients might be swabbed later on for COVID-19. So I actually had a couple instances where there'd be some patients I'd be talking to, and I would look at their chart. I can notice they have some respiratory symptoms and whatnot, but nothing to mention of a potential COVID-19 case. And I talked to them and everything would go by smoothly. And then let's say if I had some questions for them later on, I'd come back and talk to them. There's this one instance where one of the nurses actually warned me, you shouldn't be talking to that patient because they're being swabbed for COVID-19. And this was kind of stressful for me because I actually spoke to that same patient about a half an hour ago. And so I figured, I just spoke to them. So, that made me realize that I was in contact with them. And then there was other things that came to mind, not just through co-op, but because I am exposing myself in the hospital. So right now I'm currently, living at home with my family. And it was another stressing factor as a student that I had to think about because I'd be not only be putting myself at risk at the hospital, but I'd be potentially bringing home that risk, back to my home and family. And so kind of like Gary mentioned about how some hospitals have stopped with the teaching. So I know that most of the rotation students from U of T and Waterloo have been put on pause. As far as I'm concerned right now, co-op students at Waterloo are still continuing to work, although they are given the option to opt out if they like, depending on their preference. Now, in my situation, my hospital made the decision that visitors and students would not be allowed in the hospital, which is why my co-op term ended early on in that case. So, and for various safety reasons. So like for me, it was just a very interesting situation that unfolded because never would have I ever imagined that as an early second year student would I ever encounter like a pandemic situation like this. Now, that being said, I will say that for my classmates who are still in co-op, that are still practicing right now, I will say that I'm very proud of them for putting their life on the front line, as with other pharmacy professionals. I've heard various comments that employers would be commenting how a lot of my colleagues and classmates, which are students, are still contributing to the cause and ensuring that patients still get the care they need during this COVID-19 pandemic.
Thanks for your perspective, Josh. I have one open question for our panelists today, and that relates to things we're hearing on a daily basis around the need to increase capacity for testing of COVID-19. Certainly, knowing that there's a shortage of PPE is one of the barriers to testing in the community. And as you know, the province has set up these assessment testing centers, and more of these rapid point of care testing diagnostic tests are available. Spartan just got approval, Spartan Bioscience from Ottawa, on a rapid test. And as we liaise with government and we're talking to pharmacists, we're trying to ascertain the appetite essentially for doing this in pharmacies. And to do that, we would have to have the regulatory environment changed in order to permit this. But maybe I'll start with you, Chelsea. How do you feel about that? I mean, if there was the opportunity to do that and contribute more testing so that we could better understand the problem, and if we're flattening the curve, and potentially in the future, this would be an area for more involvement in point of care testing for the profession. But how would you feel about that?
I guess it would depend on, if it's for right now during the pandemic, the workflow is already so sort of maximized out that if the testing was something they wanted us to be doing in the pharmacies, whether we would be getting additional staff or a nurse or someone to come in to help do all that, then, it might be a good idea. I think it's just kind of trying to manage all the resources we have right now with what's going on, and then being able to actually add something else on top of it. I think it would be good, like you said, you can just kind of get an idea about what's happening and having the people in the community being able to come and get tested. But I think at the moment, it's good we do have those testing centers that are set up. I think it would provide a bit more access to the general public, because right now I think the testing centers, when I've talked to public health, are just for the people that they refer. So this way it would be a little bit more open and available and easy access for kind of everyone. But I think it would be kind of figuring out those logistics on how that would all work.
Yeah, and as you probably saw, the US has enabled all pharmacies to participate, and I believe it's an opt-in model. So depending on your workflow and operating environment, it may or may not be conducive, and whether or not it's something that each store would want to participate in. But I think, it's an important step to show what pharmacies can do and contribute a solution, understanding that everything you just said around the support and the apparatus around it is critical, but certainly an area that I think is worth exploring. Gary, from a hospital's perspective, do you see any role for testing, or do you think that's more of a community-based service?
I think it's a great idea. So you have to remember that we have 5 retail stores in our hospital setting, and we also have many clinics and ambulatory pharmacists. And getting the opportunity for them to be involved in this, I think, is a great idea. However, I just want you to realize operationalizing this becomes a little bit harder. This test, as you've alluded to, I just want you to realize that if you're bringing in potentially COVID positive patients, how you manage this in each clinic and in each pharmacy is going to be challenging. We're not used to these infection control concerns. And so I think that looking into that process becomes important. There's no doubt that in the hospital setting right now, our testing availability is good. But still, patients that are only symptomatic are being tested. And you're right, understanding, doing surveillance testing and understanding the true prevalence of this disease would be very beneficial. I just want you to realize, testing patients and having the IPAC concerns would have to be addressed.
All great points and well taken. Josh, do you have any other thoughts on point of care testing as it relates to COVID-19?
Right. So I think my comments would be similar to what the following speakers would have mentioned. So as we know, the pharmacy right now is undergoing through a new challenge throughout this COVID-19 pandemic. at least from my knowledge from the hospital perspective at Markham Civil Hospital, we have a dedicated testing center now that's also remotely separated from the hospital. So that ensures that patients that want to get tested don't put others at risk in the hospital by entering the hospital in the first place. From a community testing, although it is a possibility to consider, as it was mentioned earlier also, there is a potential risk that, you would be bringing potential COVID-19 positive patients come into the community pharmacy, let's say, for instance, if that were a thing. And, that could potentially put either as staff at risk or as well as other patients that would be coming in. I mean, that's not to say that point of care testing could be done for potentially, other conditions that, as that was brought up before in previous talks. But definitely during the COVID pandemic 19, it is a very unique situation. And so, there are some barriers that we have to face, but maybe that's something we could still potentially consider later on, depending on how the situation unfolds.
I want to thank our guests today for joining the Pharmacist Matters podcast. Be sure to watch my bi-weekly video that will be distributed on all social media platforms. It's a video that talks about what the Ontario Pharmacists Association is doing for our members and how we are advocating on your behalf. Our next episode will be in May. Pharmacist Matters, and we are now on multiple platforms. We can be found on Apple, Google Music, and Spotify. Stay safe, everyone. Be sure to tune in next month in May for episode 3 of our Pharmacist Matters podcast. I want everyone to stay safe and happy, and we look forward to chatting in the future. Thank you.